Dr. Subhashini K, who is professor and head at DIPMA Pondicherry, to talk about integrating structure function analysis for assessment of glaucoma.
Thank you, Dr. Shalini. So what we had been seeing so far is how to assess the structural and the functional progression. Now we shall see how to integrate this, both the progressions and so this, I will just first tell you about this Garvey-Heath map, based on which all the combined reports and the combined, the integrated thing is based on. So this Garvey-Heath map is actually a spatial map which between the visual fields and the optic nerve head. And you can see here in the small circle at the left bottom, so that represents the optic nerve head, which is divided into 6 sectors. And you can see the 24-2 field and the numbers within those visual field locations, which is represented as circles. So these numbers actually, they correspond to the sectors of the optic nerve head. So some of you might be having this Glaucoma Forum Workplace, so which is a software which combines the HFA, the fundus, as well as the OCT displays. And this is a combined report of the 24-2 field. Here you can see the OCT display is flipped and to correspond to the visual field area. And you can see the superior arcuate defect and corresponding the optic disc, the OCT changes in that particular sector is corresponding. And similarly, you can see the 10-2 and the glaucoma ganglion cell analysis. This combined report again, you can see the corresponding, the defects in the fields which correspond to the OCT changes in the GC-IPL complex. And similar to the combined report, so there is a progression analysis combining this OCT as well as the fields. And this is for the RNFL, and this is for the GC-IPL. So you don't always see progression in both structure and function. Structural damage can precede the functional loss, and functional deterioration can be detected even in the absence of structural damage. So why does this disagreement occur? So this is because of the different algorithms that are employed to assess the change and the variability of the measurements over time, and to the different scales used to assess structure and function. So there is currently no consensus on how to use the information from multiple tests to assess the progression in glaucoma. So there are researchers working on detecting this progression, combining both the changes on structure as well as function. So Medeiros et al., he developed a combined structure function index to provide a percentage estimate of the retinal ganglion cells. So Medeiros had done this Bayesian statistics joint model. So this integrates the longitudinal information obtained from structural and functional evaluation. That is, longitudinal means that is over a period of time you record all the fields as well as the OCT, and then these information is translated, and you make an inference from both. So the progression on structure influences the result of the function test. And other authors like Yu et al. Also, they developed the dynamic structure function model that uses both these measurements jointly to monitor the glaucoma changes. So the advantage of this dynamic structure function model was to give importance to both structure and function, regardless of disease severity. And it makes no assumptions about the relationship between structure and function, nor does it make assumptions about whether change should be identified first in structure or function. And for assessing rate of progression, generally the standard approach is by the ordinary least squares regression. This is a standard approach. So this one study compared the standard approach to the Bayesian joint regression model, and they found that this produces more accurate and precise estimates of the slope of change compared to the conventional method. So basically, as a clinician, whenever there is a progression in structure, but there is no progression in function or vice versa, so the clinician is confused and will not be able to take a correct decision whether to start treatment or step up the treatment. So so the integration of the structure and function will help a lot, and still work continues on this integration. Researchers are working on identifying the most sensitive combination of structure functional parameters for early detection of progression, and they are even working on more than 2 parameters jointly, and also to use patient information like the intraocular pressure that is also taken into account while predicting the progression. And the status and the rate of progression in one eye could also be used to modulate the detection of progression in the fellow eye. So in summary, current efforts, they focus on optimizing the various models to identify progression, and this will in fact help us to reduce the time for detection and prevent blindness from glaucoma. Thank you.
Thank you, Dr. Subashini, for wonderfully summarizing our instruction course on structure and function progression in structural and functional tests for glaucoma.
Thank you all for sitting through this IC, and I know it's close to tea time and you all must be really tired. So thank you for being here.